which brings us to the last speaker of this session, to Barbara Burmen. She is a young scientist, postdoc at the Medical Research Institute in Kenya, associated with the University of Cape Town. And she got numerous awards and very much acclaimed because of her outreach activities, mentoring activities, and the initiation of a large number of health programs concerning the containment of HIV and tuberculosis, and recently, of course, COVID. And I'm very much looking forward hearing how Africa copes with that problem, because the numbers are surprisingly good. It's not that the most developed countries are to invest in this race for health.
Thank you very much for the kind introduction. So good morning, good afternoon, good evening from wherever you're listening to me from. It's my pleasure to present to you the results of tuberculosis field research conducted in Kisumu County of Kenya to enhance TB control both in children and in adults, as well as among people who have drug-resistant TB and drug-susceptible TB between 2015 and 2016. The focus of this analysis is on the contact investigation portion of the study, and specifically for children. So next slide, please. At the time of the research was conducted in Kenya, amongst the tribes that contributed to 80% of the global TB area, this is Kisumu County, you can see pointed by the arrow there, which has a population of 508 people per square kilometer. It's a high TB burden area, which has 1.5 times the TB case detection rate of the nation is aged less than 5 years. Next slide, please. So what are the known global strategies to end TB? This range from vaccination, case finding, prophylaxis, chemotherapy, and other interventions that address the underlying causes of TB. The focus of this presentation will be chemoprophylaxis and chemotherapy, as both prevention and treatment of TB is essential to TB prevention in childhood. Next slide, please. The approach we employed was a household TB contact investigation study in Kisumu County, done between 2015 and 2016, where all household members of a TB index case would be invited for screening. A household member had to spend at least 7 nights in the home, the person who was a TB, over a period of 3 months preceding the TB diagnosis date. The analysis compared the proportion of children aged less than 5 years from tuberculosis and Isoniazid prevention therapy registers who received Isoniazid or were diagnosed with TB before 2014, which we will call the contact invitation period, where contact investigation was not standardized, and after 2015, the contact investigation period in which contact investigation was standardized. Next, please. So this study, which is operations research that relied on what is existing in the facilities, was done in 10% of the TB clinics in the county, recruited about 1/5 of the TB index cases from that region over that period of 2 years. 80% of the index cases had at least one household contact, and 23% of those household contacts were children aged less than 5 years. Not shown on this slide is that 44% of all index cases had at least one child living in the house at the time of TB infection. Next slide, please. So I wish to highlight some of the challenges that were faced in this process of identifying contacts. As the TB program at that time did not list the household members of any TB index case on the TB card, which is the yellow card shown on the left, the study adopted a family testing approach, which is currently has been used for family members of persons who have HIV. As you can see on the slide where it's highlighted in red, a person who is HIV infected, they have a list of all the family members documented on the card so that they can be invited for testing. Next slide, please. Additionally, here in developing countries, Kenya and other countries to mention, we do not have a proper physical address system. So we had to document actual directions to homes of individuals. Written on this card is, a light at this bus stop, cross the road and follow the tarmac road, pass a a block of houses, then at this home, ask for so-and-so, and then ask for this other person. So we used that on the study locator form, which is put on this other side of the slide. And this is what we used to try and identify people's homes, which was also quite challenging when we would need to go and bring people home to the clinic for screening. Next slide, please. Furthermore, all study visits were made with the institutional vehicle, as shown on this slide, which is branded with an institutional logo. As the program was known to conduct home-based HIV testing for a long period of time, and this testing was done by field testers who were actually operating on foot, walking between homes. If your home was targeted visits to a particular home with an institutional vehicle, arose a lot of stigma as people assumed the HIV program vehicle is coming to your home. So it's a possibility somebody is HIV infected in that home. This was not really welcomed by potential participants of the study, and there would be actually people giving wrong directions to their homes. Next slide, please. So an additional challenge that was not highlighted on the previous slides is the high number of contacts eligible for screening in this high TB burden area. The average family size is 3 to 5 in Kenya. So when you mention that one person has TB, you're thinking of screening about 3 to 5 people who are living with this person, and there may be more. But potential solutions to these challenges I've mentioned in the previous slide is having targeted screening for high-risk contacts, as well as waiting and health education for the others, using of family cards to document contacts. In communities, there are people who are called community health workers who have registers of community members and family members and where they live. Individuals can help you trace and track contacts of any persons you need to do any screening. And maybe with time, we may also have improve our physical address system. Where we had refusals and where we have contacts who are related to the index who refuse to get screened, we could look at possible legislation where we are talking of infectious diseases like TB. As much as this is in the law, it's not really enforced, and health education to encourage people to willingly come for screening as opposed to forcing them to come for screening. And where we have lots about migrations, we could actually use interlinked referral systems between regions. I will address the issue of health information systems in subsequent slides. Next slide, please. So moving on to diagnosis and management of TB in children, almost half of all the children were eligible for chest X-ray screening, which is what we are using for diagnosis in this study, either through being symptomatic or having a positive tuberculous skin test. Only 71% of these children had a chest X-ray done, and 7% of them were diagnosed with TB. So among this population of children aged less than 5 years, who were 346, 2.3% were diagnosed with TB. So we had a TB prevalence of 2.3% from this study. Next slide, please. So among those who were not diagnosed with TB and were therefore eligible for Isoniazid preventative therapy, only 16% received Isoniazid preventative therapy, with only a fifth of them completing it. Next slide, please. So the suboptimal TB diagnostic rates could be due to the type of low sensitivity and specificity of the type of tests we are using. You know, the challenges of doing chest X-ray screening, as well as getting sputum samples from children aged less than 5 years of age. Low IPT initiation and completion could be attributed to poor risk perception, as well as APT drug stockouts. Potential solutions to this problem could be to use improved screening algorithms for TB in children, community screening in the short term, and using availing point of care diagnostics for children in the long term. The use of health education to actually alleviate the challenges with risk perception, where parents would say, my child is not unwell and there is no need to put this child on treatment for a whole period of 6 months. As the TB program was just beginning IPT administration, there were challenges with drug stockouts and other issues with the records. So we proposed to avail infrastructure to support diagnosis and diagnosis of TB, as well as treatment in terms of both prevention and treatment of TB. Next slide, please. On this slide, I just want to show, apologies for the small font, but these are the columns that are in the TB register and the IPT register. These registers are not linked. So there's a challenge if you would see an index case with TB. There was a challenge to find out whether this TB index case had actually contacts who are in the TB register. And we had to actually look for some of these children manually in the TB register to look at the IPT initiation and completion rates. Next slide, please. So this is what the study adapted for database management. On this Excel sheet, this is an extract of the codebook. You can see all the subsequent sheets have more information. The TB index case had 8 data tables, and the contact had 8 data tables. So the index case was given a unique identifier, and the contacts were linked with an identifier linked to the index case, such that we had a relational database. So then the last, the highlighted box, household contacts identification, would list all the contacts the index case would tell you that they're living with at the time of recruitment. And using that, you would create the next database that has the contacts. This list of contacts identification was actually updated as you go to trace them, because you find out there are more people who live in the home that may have not been mentioned by the index case. The next slide, please. So the study adopted a relational database to support this data collection, which was actually quite complex. So this actually needed a study. Actually, there are challenges setting up this database, irrespective of the fact that there were full-time staff working on this, because it needed to be updated and continuously. So potential solutions to this you could use retrospective contact investigation in the short term, because it may be hard to try and track everybody at the time the index is diagnosed, and using simple tracking tools, maybe in the paper format to start off. So the current database, as shown in previous slides, are in silos, the TB treatment and the IPT. Using the electronic relational database assisted in the study, but this was a funded study which ended in 2 years. So we hope to be able to have this type of databases linked to a physical address system in the future. And we realized there is a need to set up a totally new system to monitor this contact investigation and TB prevention for children. The databases for TB were already electronic, and them could be overlaid on this. And next slide, please. So central to all the issues identified in this study is the resources required by the patient, the TB program, and specifically to support the data demands that require rapid access to information. Most patients actually had to pay for, usually that is in a study, we support their transport and their tests and everything, but in a normal programmatic context, you are actually asking the patient to go and bring family members, asking them to make extra visits and make extra costs to bring other people for screening. A potential solution to this could be to use community screening and IPT delivery for persons who screen negative. The large number of children who are eligible for IPT. In this study, we saw there were actually more than 80% because we were using chest X-rays. It's actually justified to give Isoniazid where the prevalence of latent TB is high. But in the long term, we may need to define what is the gold standard for latent TB in this population, as opposed to putting a large population of children on Isoniazid, where we would have challenges in monitoring them over a 6 months period. We suggest also ingraining the system of tracking into the existing community systems which have been in existence since 2005, where we can have community health workers do community screening and refer only those with symptoms. We might not be able to directly address overcrowded housing, address other challenges which I'll show in the next slides, because this is something that starts maybe at the urban planners. Next slide, please. So was this strategy useful in promoting or enhancing TB control in children? Yes, because it provided a good entry point for isoniazid administration by increasing the proportion of children on isoniazid in the 2 years before and after the study was, 2 years before the study was introduced and the 2 years in which the study was implemented. The proportion of TB, children diagnosed with TB and who were aged less than 5 years within the study clinics remained the same in the 2 years before and after the study. However, it's important to note that in a climate of declining TB case detection, detecting an equal proportion of TB children in TB aged less than 5 years probably indicates a higher yield. Next slide, please. I would also wish to highlight other known factors which have been known for years that need to be addressed within TB control. These range from issues related to health, HIV, diabetes, alcohol use, smoking prevalence, undernourishment, and coverage of universal health services. Financial issues like population covered by financial protection, which is very low in developing countries, health expenditure per capita, out-of-pocket health expenditure, which is very high in Kenya, GDP per capita, and Gini index, as well as populations living in slums, and access to clean fluids. Next slide, please. So what next? TB control will require strategies that are innovative and efficient, employ local capacities like communities, or promote capacity building, are multidisciplinary, address a number of multiple goals as shown in the previous slide, both upstream and downstream causes, and align to both funders and country-specific targets, and most important, have a clear focus on exit strategy and sustainability. Notable to mention is a limited number of recommendations from this study have already been implemented by the TB program by the end of this study, especially as regards drug stockouts and monitoring for IPT implementation and new registers. Next slide, please. I would wish to thank so much the Pontifical Academy of Sciences for inviting me to speak at this honorable meeting, the patients and family members who participated in the study team members, and the institutions listed on this slide. Thank you very much.